Good morning, everybody, and thank you for tuning in. Give me a chance. I'm going to tell everybody about you. Good morning. I'm Dr. Godino. I'm a physician. Today, I'm happy to present to Dr. George-Tharakan. She is a clinical hematologist who qualified first as a hematopathologist in 2014, completing her MA thesis in 2016 from the University of Victoria with distinction. She identified a poorly resourced need within South Africa, and she then super specialized as a clinical hematologist from Tygerberg Hospital, Cape Town in 2019. Since then, she has been working in the private sector, currently servicing both the Mpumalanga and Gauteng regions, both as a pathologist and a clinician. She works with Albert Cellular Therapy at Victoria East Hospital and Witbank, and also does local work for Pathcare. Over to you.
Thank you very much for the kind introduction. I'm going to present today TAFRO syndrome, and it's a not very well known. And
Sorry. Here we go.
Okay, so I'm going to present to you TAFRO syndrome. And I know everybody has asked me, what is TAFRO syndrome? The point of the presentation is it's to highlight TAFRO syndrome, which is one of the very rare diseases. But it's also to highlight and bring awareness to the actual classification under which it falls, which is Castleman's disease. So this is actually the official Castleman disease awareness. It's the Castleman disease day was celebrated on the 23rd of July, 2024. And there's actually a Castleman disease collaborative network. So TAFRO is one of the sub-classifications of the Castleman disease. So these are just the references that I used for this presentation. So Castleman disease, to point out, is very rare. It's poorly understood, but it is fatal. It can be fatal. It was first discovered by Benjamin Castleman in the 1950s, where he identified a patient with typical angiofollicular lymph node hyperplasia. And it was actually unicentric, a single lymph node, which they biopsied. So it came to be that they identified a unicentric Castleman disease. The importance of this is that it is quite a spectrum of presentation. It can vary from symptoms such as B symptoms, joint pains, and fatigue, things like that. And it can extend as far as quite a rapidly fatal evolution of symptoms. So that's why I think it's important to highlight this. Also, I'm also not sure how many of us are aware of Castleman disease. In our training, I know we'd have an approach to lymphadenopathy. We'd have lymphomas. We might go as far as non-Hodgkin's and Hodgkin's lymphoma, depending on where we are training, get further information about the subclassification. Castleman disease is not a malignancy. It is a benign disorder, but it's characterized by a general lymphadenopathy and quite severe systemic symptoms. So the subtypes are unicentric Castleman's disease. As you know, it's localized. It can be managed by surgical excision. Then we have multicentric, which is, as the name says, generalized. It was during the time of HIV and with lymphadenopathy, they discovered there was also an association with HHV8 positivity. Then we got a subclassification of multicentric Castleman's disease that is HHV8 positive with HIV positivity or HIV negativity. So that's a whole subclassification on its own. Then we have the idiopathic subtype. So over the years, these classifications have evolved to the latest in 2010 when they discovered TAFRO syndrome, which is a constellation of symptoms such as thrombocytopenia, ascites, reticulin fibrosis, renal dysfunction, and organomegaly. And then we have the POEMS-associated multicentric Castleman's disease, which has the characteristic polyneuropathy, organomegaly, endocrinopathy, monoclonal plasma cells disorders, and skin changes, and then the not otherwise specified. So in the US, the incidence is reported to be 2.2 per 100,000. But even this, they say, could be an underestimation due to lack of awareness and reporting of this condition. And if you ask me about the local setup, it's also difficult to say because similar to the US, I wonder how many people are identifying it. We as hematologists do see the patients after a lymph node biopsy. I myself have seen maybe 4 or 5 multicentric Cosselman disease in my practice, in my limited practice. And I've identified one lady that came to me that would probably fit in with the TAFRO syndrome. So it is rare, and I don't know if I didn't know about TAFRO during my REG program, whether I would have identified it. Okay, so the classification of the disease is from one spectrum to the other. We've got the unicentric Cosselman disease till the clinically multicentric, and the other extent, the extreme extent being the HHV8 associated MCD, which is HIV positive or negative. So characteristic features include hyaline vascularization as one of the pathologies of the lymph node. And that is majority seen in the unicentric, tapering down to the HHV-H characteristic of a plasmacytosis with a hyperplastic germinal center. So throughout the spectrum, we have regressed germinal centers, follicular dendritic cell prominence and vascularity. And with the idiopathic variant, we have a mixed variation of both. So this is just to give you an idea of what the grading may look like. So we've got regressed germinal centers. As you can see, that is the extreme. The number 3 is where you see the most regressed germinal center, whereas 0 is the normal germinal center. So you can see the characteristic germinal center pattern. And then you get your follicular dendritic cells that are more prominent. No, it doesn't. Okay, and vascularity, where there's an increased vascular, you can see the vascular islands, the red, the pinkish in between the swirled pattern. And you get your hyperplastic germinal centers and your plasmacytosis. So instead of a variation of cells at the bottom, you get a kind of a monomorphic appearance of the cells. Right, then the histological appearance of TAFRO. Typically, A and B, that is the bone marrow changes that you see, and C and D is the lymph node changes that you see. So H basically highlights the larger nucleus cell, multinuclear cells. Those are the megakaryocytes. So it's characterized by megakaryocytic proliferation. In B, you have the black stranding that is due to the reticulin stain that we've used, and it's a reticulin fibrosis. In the C, you will highlight the brownish colors in the center in a roundish pattern, and that is the follicular dendritic cells that have been stained with the CD23 stain. And in the D, you'll see kind of like this sheet, a concentric circle of mononucleus sheets, and it gives this kind of with the central polar, that is the germinal center. So that is called the onion skin appearance or a lollipop appearance. Now, the other features are the histological changes that can happen, but not always present. In the lungs, you can get a peribronchial, periarterial inflammation, lymphoid follicle formation, fibrotic changes with eosinophilic infiltration, lymphoplasmacytic proliferation. In the renal system, you get a membranoproliferative glomerulonephritis-like changes, double contour of the glomerular basement membrane. In the lymph node, as we've mentioned before, the regressed germinal centers, follicular dendritic cell prominence, hypervascularity, and increased plasmacytoid cells. In the bone marrow, reticulin fibrosis, megakaryocytes that are increased. In the thymus, you can get thymic epithelial lymphoid hyperplasia. So the clinical features, and here I'm going to focus just on TAFRO. It usually presents in the 5th decade. They are significant systemic symptoms characterized by anasarca, proven on CT scan, that there's a fluid overload, lymphadenopathies there. It could be peripheral or central, but not that bulky. They can be organomegaly in the form of hepatomegaly or splenomegaly, and a presence or increase in inflammatory markers where the CRP-ESR goes up, anemia, thrombocytopenia, and abnormal liver functions also can be present. There is not really a hypergammaglobulinemia, and there is renal dysfunction. They may or may not be an autoimmune phenomenon. And as we said, the pathological features, as mentioned before, treatment is similar to the idiopathic multicentric Castleman disease. So for the IMCD, the major criteria, you need both the typical histopathological features of the lymph node and enlarged lymph nodes of more than 2 stations. Minor criteria are more than 2 clinical and more than 1 laboratory, and that is an elevated ESR anemia, thrombocytopenia, renal dysfunction, etc. And in the clinical features, it would be a constitutional kind of symptoms, fluid accumulation, eruptive cherry-angiomata, and lymphocytic interstitial pneumonitis. So TAFRO syndrome is underdiagnosed. There's so many overlapping features that to actually make that definitive diagnosis is difficult. And it's also how many people are aware of it to identify it or say that they have seen such a patient. So it was first described in association with the idiopathic MCD in 2010 only, and it was also known as Castleman-Kojima syndrome. As we've mentioned, a constellation of thrombocytopenia, ascites, bone marrow reticulum fibrosis, renal dysfunction, and organomegaly. So we've got the histopathological criteria, which is, as we've mentioned before, and a negative LANA1 for HHV8. The major criteria being 3 or 5, the thrombocytopenia of less than 100 per 10 to the power 9, and a SARCA in the form of pleural effusions, ascites, fever greater than 30 degrees, reticulum fibrosis, and organomegaly. Minor criteria is at least 1, which is the increase in megakaryocytes and a high alkaline phosphatase without a markedly elevated transaminases. So etiology is still to this day uncertain. It could possibly be stimulated by viruses other than HHV8, paracrine cytokine secretion by a population of neoplastic cells, or an autoinflammatory mechanism. What we do know is that the JAK-STAT pathway is involved, and interleukin-6 plays a big role in this. There is stimulation of the JAK1, which is important for the cascade that leads to B-cell and plasma cell differentiation. There's production of acute phase reactants, and the JAK interacts with the P13K, AKT, and THOR pathway. The insulin-like growth factor binding protein 1 has higher level in TAFRO versus the idiopathic MCD. So the VEGF also has been seen to be increasingly expressed, and there's lymph characteristic subsequent lymph node proliferation and disease progression. It affects the lymph node structure and morphology. The VEGF is produced by the bone marrow stromal cells, which is important for vascular permeability and angiogenesis. This leads to vascular leakage, endothelial damage, and stimulates IL-6 production in the bone marrow. So it's like this vicious cycle that keeps going. And these patients present with a sort of a capillary leak syndrome in all the different organ systems. So the NF-kappa B is activated, as we've mentioned, and we know that IL-6 is a potent inflammatory cytokine and regulates hematopoiesis and immune responses. There can be an autoimmune dysfunction seen in half of the TAFRO patients, and there has been antibodies detected again, and rheumatoid arthritis, platelet antibodies, Sjögren's syndrome, etc., need to be also excluded in these patients. The thrombocytopenia is not, the etiology is not entirely certain. It's believed that these splenic macrophages phagocytose the platelets, and they form antiplatelet antibodies that cause hypersplenism and thrombocytopenia. So as we've mentioned about the clinical presentation, the TAFRO syndrome versus the idiopathic plasmacytic lymphadenopathy with polyclonal hypogammaglobulinemia, that is the IMCD not otherwise specified. So in this one, we can see the features are similar in terms of histopathology, where TAFRO has more thrombocytopenia and severe anasarca. The non-TAFRO version has thrombocytosis with a hypergammaglobulinemia and a plasmacytic kind of predominance. All throughout the spectrum, you've got constitutional symptoms, renal function can be present in hepatosplenomegaly. So the challenges are in the diagnosis and treatment. There is no specific biomarker of disease, and the spectrum of non-specific symptoms makes it unclear. So we know HHV8 positive MCD is easier to diagnose. There's a positive LANA staining with the characteristic MCD lymph node histopathology. And because the B cells host the HHV8, targeting the B cells with the monoclonal antibody CD20, which is rituximab, will help with B cell depletion and is highly effective. So there has also been, to add to this whole confusion, another newly described hyperinflammatory cytokine syndrome associated with HHV8, or Kaposi sarcoma-associated herpes virus. And it is giving the kicks, so it's the KSHV inflammatory cytokine syndrome, which is characterized by elevated IL-6, and it has clinical inflammatory symptoms similar to MCD, but these cells do not have the characteristic MCD lymph node histopathology, and they have smaller lymph nodes than the HHV8 associated MCD or the NOS. And obviously the TAFRO IMCD are HHV8 negative. So other diseases, as I've mentioned, that should be excluded, the SLE, infections like EBV, neoplastic diseases like lymphoma, POEM syndrome, and cancer. So the management algorithm, first-line therapy, steroids help. Sometimes it helps, sometimes it doesn't, and it may not be a sustained response. Oftentimes you have to add a targeted IL-6 targeted medication like cetuximab, which binds with the IL-6 itself, preventing stimulation of the cascade, or tocilizumab, which binds to the receptor and inhibits that proliferation cycle. Second-line options, because oftentimes the first line don't work, is rituximab, cyclosporin, immunomodulatory agents like thalidomide, lenalidomide, and chemoimmunotherapy like rituximab in combination with cyclophosphamide, vincristine, prednisone, or with the addition of adriamycin. And there have been reports of autologous stem cell transplantation. So this is just sort of like a dosage, just to give you an idea of what the doses would look like. Prednisolone at 1 milligram per kg per day for 2 weeks. If they're responding, tapering it down. If there is no response, adding the anti-IL-6 therapy like tocilizumab at 8 milligram per kg once every 4 weeks, or cetuximab, 11 milligram per kg once every 3 weeks. If there is a response, tapering down the steroids, and then continuing with the maintenance with these anti-IL-6 therapies. If there is no response, obviously third line, as we've mentioned before, and stem cell transplant if that doesn't work. So that is the end of my presentation. And I tried to find something. This reminded me of the lymph node, but it's lavender. Okay, so this, as I've mentioned, is it's rare, but it's there and it is potentially fatal. And these patients can present with just these constitutional symptoms, and in casualties can just deteriorate quite suddenly. So immediate supportive management and identifying the cause is very important, because also you may ask if you monitor the IL-6, whether it helps. It doesn't actually help, because some patients have got a normal IL-6 level with all these symptoms, but you still target them with an anti-IL-6 agent. Thank you.
Short and sweet.
Thank you.
I think just question. I think during my time in Secunda as a physician, of course, I went through a lot of patients with Castleman disease, and their presentation really was atypical. Most of them would present with the hepatitis kind of picture, with quite a lot of elevated BVs and also kind of liver failure. And most of those patients, I remember that I have to do a liver biopsy and actually come as Castleman disease. What's your experience? Because I sent quite a lot of few cases to Dr. Brayton that time, or Dr. Thompson.
Yeah, right. At that time, were they HIV positive patients?
Yes, low CD4 count.
So those are the patients we see more often than not, and they are HHV8 also positive. So these patients, we have to treat them. You have to treat them with a combination of antiretrovirals, as well as what we talked about, and rituximab helps in these cases.
And they don't actually do very well.
They do.
But they're still alive. 2 of my patients from that time, yeah. So I always remember if someone comes with a jaundice with lymphadenopathy, I always know it's Castleman disease.
And the challenge, sorry, is to explain to the patient. They ask you, do I have cancer? And what stage is my disease and what's my prognosis? And it's difficult to explain to them, no, you actually don't have cancer, but we're going to treat you with chemotherapy. And it will, and they present in all these weird and wonderful ways with quite bulky disease as well in some cases.
The things that I think of during our time, we don't understand, we call it Castleman lymphoma.
Yeah.
Which has become a cancer, you know what I mean?
Yeah. Although they do say if you follow up a patient with Castleman's, they can develop lymphoma or other cancers later on, like diffuse large B-cell lymphoma.
And then the role of HHV8, is it because of that's it? I mean, we never get to see patients that actually present with a herpes simplex type 8 clinically. We only it's in literature, that's when it says isolated patient like Castleman lymphoma. The question that is there a way of picking up earlier that somebody, how is actually people get HSV8? How do you get it? Is it sexually? Because other type 2 is actually type 1 is normally you can get it through like oral fecal route also. And the question that with the 8, where do you get it from? Who got it actually? How do you transfer it? Any idea? No.
We often just see them after.
Exactly, but we don't know how clinical they actually present. Eh?
Sure.
Yeah. And then you also mentioned the role of thrombocytopenia. So basically, you're saying that there's somebody thrombocytopenia. I mean, we've seen quite a lot of presentation with the thrombocytopenia, but we never really added Castleman into it. And I think perhaps should become one of differential diagnosis in retroviral disease positive patient.
Definitely to consider it in retroviral disease patients, but I mean, they would usually present with a lymphadenopathy and all these other characteristics, and it's not specifically for TAFRO, but just for the MCD itself.
But sometimes can you misunderstand it as reactive lymph nodes if you don't know?
You can misdiagnose it because of that.
Any questions?